Thank you. This is really difficult. We've got a panel that has been in demand for several years from participants at the Healthcare Forum. Past participants have wanted to hear more about what is going on with mental health in the state of Montana. Um, Child mental health, adolescent, veterans. We've got a broad spectrum of areas that need to be covered. And we are very, very fortunate to have Dick Brown here today. Dick has been active in healthcare in the state of Montana for a number of years, and he knows the rural nature of healthcare. He knows all of the facets of facility, and he is a great moderator. He will be introducing the topic today as well as introducing the panelists. Please welcome Dick Brown.
So Tanya, before you go too far, this wasn't in my job description, but I did have to check it out that, Tanya's thanking the sponsors and all of these volunteer leaders and panelists, and she's not acknowledged at all by anybody at this point. So I did ask Stacy if I could do that, since I don't know if that'll happen. If it happens again, that's going to be great. But let's thank Tanya for facilitating these couple days of conversations about healthcare and the needs in Montana. Couldn't have found a better spokesperson this year, so let's do thank Tanya. And I do have a gift for you. So the Montana Hospital Association earlier this year launched what we're calling the MHA Montana Health Improvement Initiative. This started back in 2015. We were looking at the healthcare industry in the state and why are we here? What are we all about? We changed our vision of the association to become a top 10 healthy state. This was prompted by a discussion about America's health rankings, and some of you have checked out America's health rankings, and if you haven't, you should go do that. There's about 25 parameters or measurements within the health rankings. We were talking yesterday about measurements and clinical issues, etc. So we looked at the top, or those 29, and Montana for the last several years has ranked kind of mediocre as a healthy state. We've been 27th, we've been 23rd, we dropped back to 24th. We just don't seem to get over the bubble. And we realize that if we're going to improve or build healthy communities, we really have to improve the health of Montanans, of ourselves, and of our neighbors. And to do that, all of you have to get involved in your communities. So we selected 4 specific parameters to work on. We know you can't work on everything at the same time, and this isn't a one and done year. This is a long-term commitment, and many of you are there already in your communities. So we selected 4 specific areas to work on. We highlighted this on our annual convention this year. We've done op-eds in the newspapers. Some of you have read some of this over the last several months. So we looked at immunization. We rank 45th and 46th in the state for immunization of our children and adolescents. We invited people from the facilities, people from industry, people from outside the industry to work on these individual topics. It was interesting when we got into the immunization conversation, we found that we need to focus on the elder population for immunization. They're the ones who are bringing things back to the kids, so it's really kind of an interesting eye-opener for all of us. Second bucket was obesity. And is where do you start in obesity? Montana, actually, that was one of our better outcomes. As we rank really high compared to the other states. We're like 11th, which in my mind was a really sad story of the state of affairs in this country, that we're that good in Montana. I don't think we are so good as a state. So we're looking at what do we do about children's food, their exercise habits, and outdoor sports, and then looking at adults. So whole new conversation for us, and we'll be coming back to some of you folks for some of this. Third bucket was access. And we had two prongs in that. One was uninsured population. We ranked about, we were 20, almost 20-some% uninsured in the state a couple of years ago. Worked hard on Medicaid expansion, as most of you did. ACA, good, bad, or otherwise, has had an impact. We're down somewhere into 7% of the people in this state are uninsured today. The other component of access was providers, healthcare providers. We need more physicians at all levels, nurse practitioners, PAs, etc. So that's an area that we're working on. But the bucket that is the most challenging, which really fits with this particular topic, is premature death. Montana has a really bad record for premature death, and within premature death, there's a list of about 15 other items just within that particular one, so you can't get into everything. You know, we do support seat belts. We do support helmets on motorcycle drivers. Those folks show up in our ERs or hospitals, and it's just not a good situation. But the one we're really focusing on, two things: prescription drug abuse, the opioid abuse, and suicide. Montana ranks number one in suicide of our young people and all adults in Montana across the country. The mental health, behavioral health issues in this state impact the suicide, the opioid abuse, the obesity. You go back and you can connect the dots to all of these things. So I'm very pleased that they did put this topic on as a topic of conversation. I will be listening to it during the legislative session, and this has to continue on and on and on. So we've brought a panel of great experts from the state to talk about their perspectives and where they're coming from on these issues. I think we'll let them speak. We'll have time for some questions, and we'll be on our way for the day, and you can reflect on this as you're driving home. So I think in the order we're going to do this, Karl Rosten, head of the Suicide Prevention Division for Montana with the Department of Public Health and Human Services, will start. Most of you know Matt Kuntz with NAMI Montana. He'll be next. Representative Ron Ehli, you listened to yesterday in the legislative panel. He will be up again. And then Dr. Arzubi, who just was up, and he will continue that conversation that he shared with you a few minutes ago. So you're up.
All right, well, thank you very much, Dick. I've been asked to talk a little bit about the Suicide Mortality Review Team, some of the findings that we have, and more importantly, some of the recommendations that we have made. For those of you that don't or aren't aware with the Suicide Mortality Team, this is a team of six people that were appointed by the governor, including myself, and we review every single suicide that occurs in the state. We get the death certificate, we get the coroner's reports, we get health records, we get mental health records, we often get school reports, we often have, many times we have families contact us. The important thing about this is that we're the first state in the country to do this. We're the only state. Now, since then, it's been interesting that I just got a call from New York this morning about that they're starting to do a process where they want to review and they want to know how we're doing this. So this is something that we started with. We started with in 2014, and it's starting to build. We're starting to see a number of other states that want to do similar things. So I want to just talk a little bit about some of our findings, kind of put the issue in perspective, because a lot of people don't understand just how big of an issue this is, what goes behind us being number one in this issue. And then more, as I said, most importantly, I want to talk about some of our recommendations. So what we do know is that unfortunately this is an issue that's getting worse in the United States. We've seen a 28% increase in the number of suicides nationally over the last 15 years. We are currently at a 30-year high for suicide in the United States. 2014, which is the most recent national numbers that we have more than 42,000 suicides in the U.S. That's about 117 a day, one every 12 minutes. Our current rate nationally is 13.4, and that's important because when we start talking about Montana and specific populations where we have a sparse population, numbers don't always tell you the story, but rate does. As Dick mentioned, we currently have the highest rate of suicide in the nation. For 2014, we had a rate of 24.5, which is almost double the national rate. Now, what's important to understand that this is not a new issue. We've been in the top 5 for the last 40 years. And if you go back to 1918 when we started keeping statistics, we've been a top-tier state for suicide for nearly 100 years. Now, I mentioned for the review team. So for the reporting period that we looked at, we started January 1st of 2014. And for the next 26 months, we gathered all the data about every suicide that occurred. During that period of time, we reviewed 555 suicides in our state. We now have a rate of 28.5. So why Montana? What is it about Montana that makes it so high? What's important to understand, it's not just Montana. It is the Rocky Mountain region. And it's also important to understand, when you take a look at the state, the national map, states in red are the top 10 suicide. So it's not just Montana, it is the Rocky Mountain region. And what a lot of people don't realize is we're not talking about one specific factor. We have multiple factors occurring in our region, all happening at the same time. We have, when it comes to suicide, we have a perfect storm in the Rocky Mountain region. And there are a number of factors, and I'll just briefly go over some of them, and some of it's based on the findings from the review team. We have social isolation, greater distances between ourselves. We know that that's a factor. Montana has 6.7 people per square mile. The national average is 88.7. We have lack of mental health resources in our state, especially in psychiatry. We have issues with substance abuse. Nationally, about 22% of the people who die by suicide have alcohol in their system at the time of their death. Montana, 42%. We have access to lethal means. We know nationally about 50% of the suicides are done by firearms. In Montana, it's about 63%, including 63% by our kids. We have issues with socioeconomic, as far as uninsured folks, and also unemployment and poverty. In Montana, 19% of our kids live 100 to 200% below the federal poverty line. We have issues with altitude. We know that altitude is a correlation between, a correlation between suicide and altitude. That above 2,500 feet worldwide, we see a spike in suicides. Well, the average suicide in Montana occurred at 3,500 feet. So we understand that component. We also, though, one of the biggest issues that we have is that we have huge issues when it comes to stigma, especially around mental health and especially around depression. We know that nationally they say that about 90% of the people who die by suicide have an identified mental health issue. Well, we were able to look at those numbers. In Montana, it's about 83% had a history of. So it wasn't that they were identified or had an identifiable, they had a history of mental health issues. And the most prevalent one was depression. 69% of the suicides that had a mental health history had a history of depression. We have to get better at recognizing and treating this. When we take a look at rates, so we mentioned here, up here, you'll see that these are the rates for different populations. And one of the things that's really important to understand is just the fact that we live in Montana, unfortunately, double or triples our rate of your risk of suicide. So you see the 28.5. Well, the national rate is the 13.4. Take a look at the rate of suicide for men, 45. The national rate, 21.1. Take a look at the rate for women, 12 nationally. In Montana, 6. Take a look for our kids. The national rate for suicide for 10 to 17-year-olds is 11. In Montana, it's 4. Nationally it's 4. Our rate of suicide is almost triple for our kids than the rest of the country. Age group wise, you see that the 35 to 44-year-old age group is the highest. This is slightly different than national, which is usually the 45 to 65-year-old. In Montana, it's the 35 to 44. But even that population is double the national rate. Take a look for Caucasians. The rate is 28 in Montana. National, it's almost half. Right? And our American Indian population. So many times we talk about they have the highest, and they do have the highest rate in our state, 35.5. But even compared to national, which is almost a third of that. 10.8. Take a look at our veteran population. 65. Our rate is 65 for our vets. The national rate is 22. We now see there's a positive correlation between education. You can see that the rate actually drops. So we can see that education is a protective factor. That as the more educational achievement you have, the lower the rate of suicide. And also, we're starting to study relationships. Where you can tell, take a look at the map on the right-hand side. The rate of suicide for someone who is single, divorced, or widowed, 52.6. If you're single, almost 32. So being married is a protective factor. Now the YRBS data. This is of interest. This is interesting stuff here. This is a measure that's done by the Center for Disease Control. It's done about 80% of the schools nationwide. And it measures 45 different categories of health. Seatbelt use, amount of sleep they get, whether they're depressed. So all this type of 45 different health categories. Depression and suicide is one of the measures that they look at. And specifically, what they have taken a look at is, have you made a suicide attempt in the last 12 months? Well, in Montana for 2015, 8.9% of Montana high school students have made a suicide attempt in the last year. To give you a number, that's about 3,700 kids in our state in high school that have made a suicide attempt. Not had a thought, not had a plan, made a behavioral attempt at suicide. It's highest among our females, which we know has the highest rate. It's highest among our ninth graders for high school. And it's highest among our American Indian youth. One thing that you can see from the bottom there, even though the major graph didn't show, what's even more disturbing, 11.6% of our 7th and 8th graders have made a suicide attempt in the last year. That's about 2,700 kids. 12 and 13-year-olds have made a suicide attempt in the last year. Now, one of the things that OPI did with the YRBS data is that they started to compare kids who've made a suicide attempts to kids who haven't, to see how they ranked as far as all the other health issues. Every single health issue that came up, kids who have attempted suicide had a higher risk. They drank less milk. They were less likely to get 8 hours of sleep. They were less likely to wear a seatbelt. They played more video games across the spectrum. Now, some of the highlights that we see, they also were more likely, almost 3 times more likely to drive while intoxicated or while have been drinking. They were 5 times higher risk of being physically or sexually assaulted. They were twice as high to have been bullied on school property. They were 3 times higher to be electronically bullied. They were more than 3 times more likely to have smoked a cigarette in the last 30 days, and they were double the risk or double the rate of smoking marijuana. So think about these kids in 10 to 15 years. What are they going to do to our healthcare system? And not to mention, how are they doing academically? Probably not very well. So when it comes to the recommendations, boy, this is not working out too well. So the PowerPoint, let me just tell you. So one of the things we wanted to do with the team is that we took a look at from elementary school, middle school, high school, adults. We wanted to come up with recommendations. So when we talk about one of the major factors that we saw, especially with elementary kids, is that we saw an incredible lack of coping skills and resiliency skills. A very high lack of ability to deal with adversity. So we've been looking at programs that have been shown to help with resiliency. One of the programs that we have been implementing in small amounts over the last couple of years is one called the PACS Good Behavior Game. This is an evidence-based practice that has shown, and actually the interesting thing about this program has been around since 1969. It was created by a teacher in Kansas, and what they did is they compared kids who had gone through the program to kids who didn't, and they followed them for 30 years. 30 years later, the kids that mastered the skills associated with this game had a lower crime rate, lower substance abuse, lower suicide. It's now been, it's best practice, it is evidence-based. Certain countries, Ireland, Sweden, have implemented it nationwide. We just recently had the state of New Mexico who went statewide with all first and second graders in this program. They started to see positive effects within 30 days of implementation. So this is a program that we are advocating for, recommending for elementary schools. For when we talk about middle and high schools, one of the first things that we are advocating for is, you can see the little box there, it doesn't show up very well, but we're recommending mandatory screening for depression, starting at age 12. This is not our recommendation that we came up with. This is actually based on the U.S. Prevention Task Force, which has also recommended mandatory screening for depression starting at age 12. The reason why is because 86% of parents who lost a child to suicide didn't even know their child was depressed. We lose our objectivity as parents, so many times we don't see the signs. So having that screening gives parents the information they need to make the best decisions for their children. We are also advocating or recommending that school staff be trained. And we already have a legislative bill that recommends training for school staff. And there's a number of different resources. QPR is one that we're recommending, and that's for teachers, bus drivers, janitorial staff. We're recommending that gatekeeper training be used for all to increase the awareness of the warning signs and, more importantly, how to intervene. There's another program called Assist, which we are advocating for. This is a higher level intervention. This is a 2-day training that we're advocating for all school counselors. We're also advocating for a program called SOS, which stands for Signs of Suicide. This is a school-based program that focuses on teaching the kids how to recognize the signs in their peer group, because kids recognize it way before we do. And we also are looking at pilot programs, and the one that is just starting this fall is a program called YAM, which is a very promising program that had some initial studies out of Europe, which we want to take a look at to see if it's a good program for our state. Let's see what comes up here. Oh, the nice thing about the PACS program, by the way, for the last 5 years, that program was being tested up on the Salish Kootenai tribe, and they have created an indigenous version of it for American Indian youth. So it's now being retested out in the state of Washington with reservations out there. But so that's a program that can also serve our American Indian youth. We are also taking a look as far as the top 6 recommendations that we have made. So first of all, we want to renew the work of this team. Not only are we getting data that no one else has, including the CDC, but we are able to identify pockets where there's specific issues so we can focus resources to those areas. We are able to identify resources or factors that may be contributing to them that we didn't think about before. One of the programs that I think has been the most beneficial is we're also reaching out to families who have lost someone to suicide, and we are providing resources to families, including grief manuals, within 2 to 3 weeks of the suicide. This is a population that often, because suicide is a complicated grief, and many times people don't get the resources or the help that they need. We mentioned the PACS Good Behavior Game. For those of you that want to know about money, as far as what do you get back for your investment, the research has shown that every dollar you spend on the PACS program, you get a $55 return. We are also advocating and recommending training for primary care. Because of our lack of mental health resources, we don't have the mental health resources, so primary care plays a key role. So we want to provide resources and practical assessment tools, depression screenings, the use of the Columbia Suicide Severity Rating Scale, safety planning, lethal means counseling, and caring contact. All of these are practices that are used nationally in different healthcare systems, and we have the training to provide that in our state. We also were talking about, in addition of the addition of an American Indian Suicide Prevention Coordinator. Primarily because one of the issues that we have with our reservations is many of them receive federal grants and they have somebody who's put in that position, but we've seen a high turnover because when the grant's gone, so is the position. And so then you have somebody else who comes in at the next grant cycle. We really want to create some continuity of care with our American Indian reservations, and having somebody at a state level who would work with that, with the reservations, would be essential. We are also wanting to take a look at firearm safety. In Montana, 88% of all firearm deaths are suicides. That means 12% are homicides or accidental shootings. And as I mentioned before, 66 or 63% of our kids, and we're not talking about hunting rifles and shotguns here, almost 90% are handguns. So we want to take a look at education and awareness around firearm safety, making sure that folks know that if you see the risk factors, make sure that you safely store your firearms, lock up your prescription medications. And then finally, as we mentioned earlier, the depression screening isn't just for kids. There's been a big emphasis from SAMHSA around the high rate of suicide among middle-aged men, and one of the key issues is undiagnosed depression. So screening for the depression as the next vital sign is recommended nationally, and we are recommending it as well for primary care. And we also have some resources that we are promoting. One is the Lifeline number, of course, which is the National Crisis Lifeline. But recently, in the last 7 to 8 months, we've also partnered with the National Crisis Text Line. So this is specifically for young people. But what's interesting, we're finding men and vets are using this as well, because a lot of people don't feel comfortable talking on the phone or talking about their issue, but they will text about it. So they can text MT to 741-741, and a crisis counselor jumps back in within 3 minutes and starts an interactive conversation with the person, and they have access to the emergency response system and can initiate help if needed. We also have resources on our website. So with that, I'll take questions at the end and hand it over to Matt. So can I just close this?
All right, thanks, Karl. I set my timer so I don't go over. I know at this stage of the conference, that's probably the most important part of my speech. I'm Matt Kuntz with NAMI Montana, the executive director. We're an organization that supports, educates, and advocates for Montanans who live with serious mental illness and their families. I came into this line of work. I was a lawyer before, but I lost my stepbrother to PTSD after he returned from Iraq, and kind of started fighting to improve the system, and was fortunate that NAMI took me on. And I've been through, it seems like, 1 million legislative sessions. It might be short of that, but the way that I view it is kind of like we're trying to take a herd of geese, our bills, across a field full of foxes. With all due respect for all of the legislators in the room, but I know a lot of those geese are not going to make it across the field. Like, that is the reality, and if you're not okay with it, you probably can't be in this business for more than one session. But last session, we got a lot of geese across the field, and while you heard a lot of difficult things about our reality in Montana from Karl, the fact is we got a lot of things through, and there's a lot of good things happening. I want to thank Representative Ehli, Senator Wanson Reed snuck in. A lot of the people that worked on the interim committee a couple years ago to try to improve Montana's institutions and our crisis facilities, we're seeing good things happen, and thank you for that. The other thing that I've seen is, from a positive standpoint, everybody's fighting in politics right now. I get it. We've been through years of that, and I don't know if it's going to end soon. Probably not. But there's a general consensus on we need to do better on mental health. I was talking with a statewide policymaker the other day and about their suicide prevention thoughts, and I told them, this is exactly what your colleague on the other side of the aisle wants to do. I don't know. I don't know if that's good or bad in this situation, but you guys do want to do the same thing pretty much in a local, get it out there, things at work sort of way. And I think that's really wonderful. In the same way, there's a federal law going through on mental health reform, and everybody elected from Montana is going to vote yes from that, unless there's something squirrely thrown in at the end. And 2/3 of them have taken leadership roles in that, even if they don't tell everybody about it. So that's really helpful. One of the things that we're most excited about for suicide prevention is the Youth Aware Mental Health program that Karl brought up. And that started with the Center for Mental Health Research and Recovery at Montana State. And I want to thank Commissioner Lindeen, because the first investment in that program was $500,000 from a settlement that they had with an insurance company. And I think I'll go to my grave saying that was the best investment in Montana's mental health care system that this state will ever see. And what you see, so thank you. And what you see in that YAM program is the best in the world suicide prevention tool coming to Montana before it comes to Massachusetts or before it comes to New York. And it's a great thing. And we're excited. It's already crossing the state from Poplar to Kalispell and a lot of places in between. I also want to point out that suicide review team is focusing on really what we need to do and who we're losing to suicide. And that was, the idea came from Dr. Len Lance, a psychiatrist in the community that was upset about Montana's suicide rate and wanted to do something about it. You don't have to be a policymaker or a lobbyist or anything. That was just, Len read the paper and got mad, and now New York wants to copy it, like that. That's how good things work, in this state. The crisis bills, which I've mentioned, have been amazing for children and adults in crisis across the state. There's a place to go when you're suicidal. There's a place to go when you're in mental health crisis, thanks to the efforts of the Montana legislature. And we're deeply appreciative of that. And I want to say, for all the hospital lobbyists in the room, please come support our kids' crisis. I'm lucky to know where the bathrooms are in the Capitol, much less the back rooms. Somebody smarter than me needs to protect that kids' crisis funding. And I know it matters to you because you have a lot of kids in crisis that go into our emergency rooms, and those dollars help get those kids to a place that's not the highest level of care. In our institutions have a lot of challenges right now. With the forensic population is continuing to increase in Montana as it is across the country. Did anybody? And we also have a growing number of Alzheimer's folks in our Montana State Hospital. Did anybody read the front page of the Billings Gazette this morning? Seriously, it's free. It's free downstairs. So it would have been better if you've read it. But there are two articles, one on the top of the page, talking about a rape at Montana State Hospital in the forensic unit. I think it was in 2013. And a lot of the people in this room saw me waving my arms and saying, in 2013, we need to fix the forensic unit. We need to do something about the forensic unit. And they have done it. With Galen, not perfect, but it is safer than it was because the state's going to write a nice check for that lawsuit because that happened legitimately, front page of the paper today, that happened. And we're going to pay for not being proactive in fixing our forensic unit. And if we don't get proactive about Alzheimer's, we're going to pay the price on that. I had a loved one in Montana State Hospital, I don't know, 2010, 2011, and the unit that she was at that time for committing suicide is now full of Alzheimer's and dementia patients. That entire building is full of Alzheimer's and dementia patients. Does anybody think that that was the design for Montana State Hospital? It's not. And thanks to those crisis bills, we've been able to cover that group of 35 patients at Montana State Hospital that we hadn't planned for. But that's not where they ought to be. There's a lot of good movement about the provider shortage in Montana, the Billings Clinic, and their efforts on psychiatric residency program. We hope that there's going to be a bill at this session. I know it was talked about the interim committee, and we'll support that, along with psychiatric nursing fellowship, a small investment in helping people get involved with psychiatric nursing. We think could do a lot of big things for rural Montana. We're going to have a bill on integrative care at our mental health centers in the state, and we're excited about it. The theory is there ought to be one payment schedule for kids, adult mental health, and addiction, and there ought to be one set of regulations. The burden should not be on the providers to figure out, okay, which regulation are we on now? Okay, which payment are we on now? If we don't make it easy for them, we won't have mental health services in our state in the ways that we want them. Dr. Karl has worked incredibly hard to bring prescribing psychiatric pharmacists to the state of Montana, and they have a bill, and we're going to be very excited about supporting it. Just to show one of the issues where that could help is the prescription of clozapine in this state. It's very hard to find a provider that'll cover clozapine, which is necessary for some of our most severe mentally ill people, and prescribing pharmacists can step in there. We'll be working on Parity Act, this legislation, kind of some Parity Act improvements that we've been working on with Commissioner Lindine's office. If you're a legislator that wants to do something really cool, come meet me afterwards. We can talk about this one. But because to show how important this is, like the best counselor in Helena is for kids is probably going to quit doing her services through private insurance. She's only going to offer it through Medicaid because private insurance has more red tape than government insurance. If that's not concerning, I mean, like, that is the best counselor. That's who I took my kids to. And she wouldn't take my kids again. So the real issues we have, just to wrap it up, we have concerns about where the Affordable Care Act's going, concerns about Medicaid expansion, and I think those are valid concerns. When we met with Senator Baucus's office, and before Obama was elected, so about what later became Obamacare, it was supposed to be a bill designed for President McCain based off of Mitt Romney's package, and now it ended up as Obamacare later. But it was mostly designed to make it so insurance companies couldn't discriminate against people with pre-existing conditions. That was the main idea for that legislation. And I know that President-elect Trump says that will be part of his package, but I don't know how that'll happen, and we're scared. I had my daughter went into the hospital. She's 7, and she went in for kidneys 2 weeks ago. Scared us to death. But she could be discriminated against for the rest of her life by insurance companies if we let that go away. So I don't know what the fix is for that. I think that neither Republicans nor Democrats want pre-existing conditions to be discriminated against, but it's not magically going to happen if we don't work on it. We're excited about how the FQHCs and the hospitals are beginning to do more with mental health in the state, but it does make us concerned about who's going to care for the people with schizophrenia in our communities. Are the FQHCs really ready to step up for the people with schizophrenia and the most difficult types to treat bipolar disorder or treatment-resistant depression? And if not, how do we make sure that there is somewhere to go, because there's not always enough money to go around? And I guess last but not least, we are hopeful that eventually the state of Montana will begin measuring outcomes for mental health. I know Representative Ehli has charged up that hill with us and gotten beat down 2 sessions. It's an active process, but I think the cool thing is when we had that bill with Representative Noonan the first time 3 sessions ago, we were told it was impossible, and now nobody thinks it's impossible. Now nobody thinks that we shouldn't be doing it. It's just a matter of how and where the funding's going to come from. So thank you all for everything that you do for mental illness. I know our families deeply appreciate it. We get calls from around the state with the hardest to answer questions, and because of because of the work of a lot of people in this room, we have more answers for them than we did 8 years ago when I first took over this job. And I'm hopeful that we'll have even more 8 years after this. Thank you.
Good morning, and thanks for having me here again today after yesterday. So I'd like to just say that I'm truly honored as a legislator to be up here with this level of panelists that have been brought forward. These are frontline people that are fighting every day. I'm just a legislator. I go to work 3 months out of every 2 years and run these things up the hill, like Matt said. But it's people like this that fight this battle every day, that we, that you get to talk to, that brings mental health awareness to the front of what we need to be looking at. And that's kind of what I want to talk about today is mental health awareness. We can get really depressed when you start talking about mental health and all the things we got to do and all the things we can't get done. We can get really depressed. When you listen to Karl talk earlier about all the statistics, he's got a tough job. And the tough job that he has to do is he has to make us aware of all the things that are out there that are causing us the issues that we have. And for him to bring forward the issues of suicide, alcoholism, poverty, do you think he wakes up every day happy about what he's got to bring forth? I bet not. But it takes a real person to be able to bring those statistics forward and continue to get up the next day and fight. So, it's really important that we understand how depressing mental health can be. And try to find a positive light. And that's what I want to hopefully that I can bring to the table today. From my perspective, from a legislative perspective, there is positive about mental health. And I talked yesterday, and for those of you that weren't here, that I come from the appropriations side of the legislature on health and human services. I was fortunate in the last 2 sessions to be able to be the chairman. When you're the chairman of health and human services and appropriation, you get to see a lot of the bills that come forward. You get a lot of input on what can and what should be done. And I've always really liked that position because it is what drove me to being passionate about, in this case, mental health. All vulnerable populations, as we talked about today, but in today's discussion, let's talk about mental health. So as a chairman, I've decided to give up that position, and I've moved into leadership, and I'm going to take a position. I was elected within our caucus as the majority leader. So some of the people have said, oh my God, what are we going to do now? You're the guy. You're the guy that carried some of those bills. And I said, no, it's not the person that leads Health and Human Service on the appropriation side. I will tell you that it was just an avenue for me to learn and to bring forward some of the things that I've become passionate about over the years. And one of them is mental health. So as majority leader, all this is just another position, a launching pad for my passion, which has become a passion for me, and that's mental health and mental health in Montana. So I want to reassure everybody in the room that from a legislative standpoint, that Section B, Appropriation, Health and Human Services, is in good hands. So we're moving a fine gentleman out of Conrad. His name is Representative Rob Cook. He's going to become chairman of that committee. And those of you that know Rob Cook know that he's going to give it 150%. There's nobody that can get into a budget and understand it better than Rob Cook. Also coming back to the committee that I have to tell you about is Senator Mary Cafaro, probably one of the most experienced legislators in the state of Montana when it comes to health and human services. And I got to talk about Senator Cafaro a little bit, because if you want to talk about positive and you want to talk about upbeat and you want to talk about how we can have a positive nature to mental health, then you have to talk about Mary Cafaro. And so I guess I learned at one point in time that you should never talk about anybody unless they're in the room, but I'm going to do it anyway. So Senator Cafaro is a Democrat, and I'm a Republican. So from all standpoints, we're not supposed to like each other. But I'm here to tell you, even though she's not in the room, I'm here to tell you that she likes me. Yeah. So, and again, that's my story because she's not in the room. But maybe that's why you're not supposed to talk about people unless they're in the room. But no, that's not my point. My point is that we're bringing back to Health and Human Services people like Mary Cafaro, who, I try to figure out how I would describe her. And anybody that knows her, and if you don't, I'm going to tell you exactly what I think of Senator Mary Cafaro. Tenacious comes up, motivated comes forward, determined, principled. Those are some of the words that I would use to describe Mary Cafaro. And I do that because there's nobody in state legislatures that fights more for vulnerable populations in the state of Montana than someone like Democrat Mary Cafaro. So I have to tell you that. In addition, on that committee is Senator Bob Keenan, Senator Olszewski, Representative Balance, who is the appropriation chair this year, Representative Kanoki, and Representative Marilyn Ryan. So you got a really good group of people that are coming back to take over that section of Health and Human Service on the appropriation side. A quick story about Senator Cafaro, because I just can't let it go because she likes me, is she's a vice chair, so she sat off to the side of the chairman. And tenacious was the word I used before, but someone like Senator Mary Cafaro, she says, she's so passionate about mental health and all the issues. And she says, Mr. Chairman, you always know when I have a question. So we have people out in the audience, whether it's agency staff, whether it's people coming up to testify, whether it's committee members. And she said, I don't even have to raise my hand. You just know when I want to talk. And I said, because I can see you, your head. As soon as she has an issue, her head pops. And she said, well, do you see me do that? I said, no, I feel this warmth on the side of my face. And I know she's got laser beams in her eyes that are just touching my ear. And so she's the person that brings me a lot of hope and to a really tough situation with mental health. So we got a lot of good people in place. Last session, Matt recognized Senator Dave Wanzenreed, which came in the room. So the interim before this last interim, he was chairman of the interim committee that brought forth and managed this bipartisan committee on mental health bills. It was the interim committee that worked hardest for my whole time there on interim or on mental health bills. And Dave Wanzenreed brought together this bipartisan committee to bring forward these bills. And those bills that Matt touched on were crisis intervention, jail diversion, dollars for secure beds within those crisis centers, short-term psychiatric care, and children's mental health. And so how do you bring, our interim committees are not known to bring out a lot of legislation, but under the direction of Senator Wanzereed, and I would like to recognize him. He's right in the back room there. Senator Wanzereed, could you stand, please? Again, when it comes to mental health, it's not about Republicans, it's not about Democrats, it's about moving forward and trying to get something done. Yesterday, one of my friends came up and said, well, I understand this isn't a mental health year, not a big year for mental health, because the interim committee has been working on Alzheimer's dementia. And I respectfully disagreed, because those crisis center bills are still in place. They're still funded. There's money coming out. We're going to reach across the rural communities in the state of Montana, and we're going to reach out to more communities to open up more facilities. Those are matching grant funds that are just going to continue to work. We had great success with them. Hopefully we'll get some of those programs in eastern Montana. So in addition to, even though we had a lot of bills coming out working on Alzheimer's dementia, there's another bill that we're going to be working on that I want to introduce to the legislature that nobody's seen yet, and I don't even know if you're aware of it, but it's called CIT Montana, Crisis Intervention Training. And it touches more on the side of law enforcement, because you've all seen across the United States, you've heard about Black Lives Matter, Blue Lives Matter, all the issues that are happening. The basis to all of that is mental health. And those are situations where either these people have not gotten help for their mental health, and not placing any blame, maybe we can do a better job from the standpoint of law enforcement to recognizing and being aware of mental health issues and how to bring that to a close more peaceably. So, totally defense of law enforcement and all the things that happen, not placing blame anywhere. It's CIT Montana is going to help us in Montana bring all of that to another level. So what is CIT Montana Crisis Intervention Training? It's a program that helps divert people with behavioral health disorders away from the criminal justice system and into the healthcare system. We've got to get these people to where we can take care of them. We talked about it yesterday about working on the preventive care side rather than the acute side. Let's talk about mental health before it escalates to a point that they end up in Montana State Hospital. That's what crisis intervention training does. Trains law enforcement to now be aware of all the issues that they potentially could run into in your jails, in the prisons. So crisis intervention training is just that. It's a nonprofit organization that's begun in Montana, has been in place for 3 or 4 years. And now we're going to bring it to a state level and see if we can't get it recognized. So mental health and the issues that we're trying to develop with the good people on this panel and the behind-the-scene works that's still in place, the positive side about mental health is we're still working on that, and we're going to continue to do that. The other thing that I respectfully disagreed with people is that the legislature is the place to go to get something done. And yeah, we're an avenue. Let's see, is it the goose and the fox or the... I wasn't sure if I was a goose or if I was a fox or if it was the bill. But yeah, we're an avenue to get something done. And Matt's right. You got to bring those bills forward, and we've got to get bipartisan support across the aisles to get good mental health issues resolved. But it's not the government that's going to get this done, and it's not legislators that gets it done. It's not the governor's office that's going to get this done. And the reason I respectfully disagree with all of that, although I understand it's an avenue, it's really the people in this room. If you guys don't come up and you don't scream at the top of your lungs and you don't bring forth your concern to the legislature and you don't push on your local legislators and you don't push on the governor, I'm here to tell you nothing gets done. So while again, the legislature is an avenue, it's not the place that you really want to go. It's the people that are most passionate and the people that believe in what they do, and that's you people in the room, the people that work in this field every day. So other than the people that actually have to deal with mental health on an everyday basis, those people with mental health issues, who are heroes amongst all of us, I say there's no bigger advocates than you people in the room. And if you really want to find a hero, about mental health, then take a look across your table and look at the people in this room that are really bringing these issues to light. Because that's what we need, and that's what we need to go forward. So my hat's off, and on a positive note, mental health awareness continues in the state of Montana. I'm going to use every position I have and every opportunity I have to keep it to the forefront. That's how we're going to eventually, solve the issues, at least take a bigger bite out of the problem. And I'm committed to do that because I know you're committed to that. So from my perspective, I want to thank everybody else involved in mental health and the fact that you're out there pushing for it every day. Thank you.
Hello again. So I think everybody here has made a great case. I mean, the colleagues in the room and here on the panel are feel very fortunate to be among them and really to take from their energy and keep moving forward. I we really need more reason to fight for mental health, but I wanted to come up with a couple other thoughts and reasons maybe we should be thinking about this. First of all, mental illness has a multiplier effect. Mental illness has a multiplier effect on the cost of healthcare and on healthcare outcomes. So, while yes, I mean, thinking to Karl's statistics that are clearly disheartening and very sad. Some of the things that Matt was mentioning and Representative Ehli. Let me come at this from a different angle. Before I became a psychiatrist, I used to be in finance. That also doesn't make me a bad person, but sometimes money talks. And so let me give you a couple other reasons to think about mental illness and really tackling this issue. Mental illness is the number one cause of medical disability in the United States. The number one cause. The number one selling medication in the United States last year was Abilify, an antipsychotic. Okay? Now, the cost of treating depression in the United States is about $115 billion a year. That's in direct and indirect costs. For anxiety, it's about $92 billion a year. So if I extrapolate this out to Montana, it costs Montana about $650 million a year. $650 million a year in direct and indirect costs are about 1.6% of the gross state product. So again, direct and indirect costs. What do I mean by that? Well, direct healthcare costs, pretty straightforward. It's a cost of going to see a therapist, a psychiatrist, a primary care doc, and the folks that get reimbursed for this sort of thing. But what are the indirect costs? Well, the indirect costs are the suicides, increased medical morbidities, and I'll get to that in a second, lower treatment adherence. I mean, for example, you're severely depressed or anxious, the likelihood that you're going to be able to follow through on recommendations by your clinicians is probably lower because you're struggling to get motivated. Lost wages by missing work and decreased workplace productivity. I actually brought some numbers to help illustrate some of this, and they're a little bit disheartening. But again, what I'm trying to do here is sort of make a business case for tackling the mental health problem. And again, we do have a mental health crisis in this state. Being in the top 5 in over 40 years in terms of suicides, that's clearly problematic and unacceptable. So, for example, there's a 1998 study. I went through a bunch of different studies. There's a 1998 study that looked at 46,000 employees. They showed that the cost of an employee, the cost of insuring an employee and taking care of that employee with no depression was about $1,700 a year. This was back in 1998. An employee with depression was about double that, about $3,200. So having a depression increased the cost by more than 90%. What's really interesting, if you look at folks who get diagnosed with coronary artery disease, if you look at just that disease, the way to predict sort of 1, 5, and 10-year outcomes are correlated with clearly somebody's physical condition. But if that person has comorbid anxiety or depression, you're going to get better idea of how they're going to do in 1 or 5 years if you look at their anxiety and depression instead of the functioning of their heart. In other words, when you have somebody with a medical condition and comorbid mental health problems, you're going to have worse outcomes and higher cost outcomes. More information. So, for example, the mortality rate of depressed patients after a cardiac event, like a heart attack, is 2 to 4 times higher than someone in a non-depressed patient. The mortality rate is 2 to 4 times higher than a non-depressed patient. Depression associated with poor blood sugar control, higher risk for diabetic complications, functional disability, and higher overall healthcare costs. There was a study of 15,000 employees at a major corporation that showed employees with depression and medical conditions like diabetes, heart disease, hypertension, back problems, spent 1.7 times more in healthcare dollars versus the medical condition alone. It goes on. 50% of all visits to primary care doctors are due to symptoms unexplained by physical illness and often associated with anxiety, including chest pain, dizziness, rapid heart rate, abdominal discomfort. Comorbid depression increased the odds of long-term disability claims by 2.2 times in patients who had arthritis and joint disorders. And depression was a leading predictor of workers' compensation claims, increasing the odds of a claim by 1.5 times. Workers with panic disorders are 5 times more likely to receive disability benefits. More, depression increases the probability of missing work due to illness by 2.5 times and is associated with 50% longer periods of lost work. The impact of anxiety and depression on role impairment at work, like sick days, work cutback days. Well, if you have hypertension alone, it's about 0.4 days a month on average. If you have hypertension and a psychiatric condition, it's 3 days per month. Okay, so we're looking at 7 times higher. Arthritis alone, 0 days a month. Arthritis with psychiatric conditions, 3.4 days a month. So I got more, but I think that makes the point, right? I mean, this there's a clear economic cost. So again, if we're not pulling on people's heartstrings, well, let's look at the purse strings, right? This is clearly having a major economic impact on our state. Now, some of the other issues that were brought up here are sort of the workforce, right? So while Representative Ehli is talking about the CIT initiative, which is going to divert folks from criminal justice system to the healthcare system, we're not prepared, right? So happy to help, but we're not prepared. So what are we going to do? Well, a couple of things. The Governor's Council on Healthcare Innovation and a couple of other stakeholders have taken on the task of working more closely with primary care doctors, FQHCs, for example, and other primary care locations to integrate behavioral health into primary care. About 75% of all antidepressants are prescribed in primary care offices, not by psychiatrists, not by psychiatric nurse practitioners, but by primary care docs. Those are the front lines. And there's plenty of statistics, and I'm sure Karl knows them much better than I do, in terms of the number of people that before attempting or committing suicide see their primary care doc. And it's a pretty short window. So what are we doing? What are we doing to support our primary care docs? We have to do more. So one of the things, again, I mentioned Project Echo. One of the things we're trying to do through Project Echo is to provide more of that support. But we need to do more. So, for example, when we are working with the primary care docs and trying to do our best to provide those necessary supports and education, at some point we're going to run out of psychiatrists. So on average, I think the national average is I think over 50% of psychiatrists are age 55 or higher, and we're not going to come up with enough psychiatrists to cover all the care that we have need for here in Montana. So one of the things that I completely support is working with MSU Bozeman, for example, to make sure we have a robust psychiatric nurse practitioner program, working with Karl on making sure that psychiatric pharmacists are given more authority to prescribe. They're incredibly well trained. We have a great psychiatric pharmacist that works on our team, incredibly well trained, and certainly capable of doing this. But also having a psychiatry residency program. So there are 3 states in the country that don't have psychiatric residency programs. Those include Montana, Wyoming, and Alaska. And if you look at the states with the highest suicide rates, those are Montana, Wyoming, and Alaska. I don't know how correlative it is or causative, but certainly a coincidence, right? So one of the things I'm going to be really pushing during this legislative session, working with Matt and Representative Ehli and his interim subcommittee, were kind enough to include in their final report a support for having a psychiatric residency. This is something we have to push hard for. We did a study, we're working with the Montana Healthcare Foundation, that found that about $2.8 million a year, so almost $3 million a year, are flowing out of Montana to cover our psychiatric shortage here in Montana. Well, how? Well, recruitment costs. So the cost of recruiting, flying someone in, interviewing them, and then having them say, no thanks, I prefer New York or San Francisco, right? You do that enough times, that gets expensive. Or having locums or temporary psychiatrists. Those are incredibly expensive. I'd argue 2 to 3 times as expensive as having a fully employed psychiatrist. So we spend a lot of money on temporary psychiatrists to come into Montana, practice a little bit, and then get out. And then the other one is, while I love having the access to telepsychiatry into our emergency room, I think it would be better to have a local psychiatrist who could see that person, see those patients in person. So what we're doing is we're importing a lot of capacity into Montana, and we're spending about $3 million a year to import that capacity. Well, guess what? It costs actually a little bit less than that to fund a psychiatric residency program that would produce about 3 or 4 psychiatrists a year. There are some great models out there. The University of Washington has a residency training track where they, among their regular residency program in psychiatry, they also provide they'll have a track where there's certain psychiatry residents who will spend the first 2 years in Seattle and then years 3 and 4 in a rural setting like Spokane and Boise. So these are proven models that have demonstrated that after graduation, 60 to 70% of the psychiatric residents who graduate will actually stay in state. So psychiatrists are not the answer to all your problems. They're just not, although we're very important. But we're never going to be able to train enough psychiatrists. But what we do need to understand is that we have an aging population of psychiatrists. The other thing is practicing psychiatry in Montana is very different than practicing psychiatry in other places, right? We're talking about integrating behavioral health into primary care. Well, we need psychiatrists who are trained to interact with primary care clinicians in a way that works, in a way that's collaborative, in a way that breaks down silos. We're talking about telepsychiatry and Project Echo. I need to have psychiatrists who are willing and able to practice in these sorts of models, right? And so I came from a very good psychiatry training program, but they are light years behind what we're trying to get done here in Montana. It's the 50-minute hour or the 4 days a week of psychodynamic psychotherapy. It's not going to cut it, right? So we have to think very differently. We have to train psychiatrists who are trained to practice in Montana with the resources that we do have, and really be innovative. Because I truly believe, and maybe I guess part of the problem of working this business and having to wake up every morning, like Representative Ehli was describing, I could either wake up and get really sad and upset, which I've done from time to time, or I can try to remain hopeful, right? Wouldn't it be great if in 10 years we could be reading headlines that show that we went from worst to first in terms of suicide rates? Wouldn't it be great if some of the innovative treatments that we're talking about here are actually leading the way? Because I really believe here, given the lack of resources and some of the other barriers, we have to be more creative than we're being in other places, and we could certainly make a difference. I'm getting phone calls from Oregon, Texas, who are hearing about sort of our Project Echo and other things, trying to find out how'd you guys do that? I mean, so clearly we're doing something right. I mean, the suicide prevention team, what's the full name? Right, the suicide mortality review team. Sorry, right. I mean, we're being creative, and we're getting other states who are calling to find out what we're doing. So hopefully over time, 10 years from now, we'll be giving a talk, and hopefully it's the same 4 people, because I respect them. 5, respect all you guys. 6. Who's the 6? Oh, okay. No, I'm not talking about you. I was talking about us here. But those 2. Yeah, and them 2. But 10 years from now, if we can be talking about this stuff and saying, wow, we were able to go from worst to top 10 maybe, because of some of the things we've been able to accomplish, I think that'd be incredibly inspiring. So hopefully you'll join us and support some of the things we're doing. Thank you.
I'll have to commend this panel for taking a very tough, depressing topic and really giving us some hope as we walk away today. I'm taking notes, and I saw several of you taking notes on various things, but beyond the statistics, there were a few success stories throughout this, but a long list of opportunities that I think we can all continue to work on. So thank you very much. We've got 2 or 3 minutes for just a couple questions. Do we have any? I'm sure there's lots of questions. Sure, is there a microphone close by?
Representative Kathy Kelker. One of the things that we know about mental illnesses is that they are chronic illnesses, and the care for people is long-term. And I'm really interested in the comments made we have to be more creative here in Montana. Do we have any notions of how to support people with a chronic illness, mental illness, over a longer period of time. Hospitals are not set up that way. What we have is short term. What can we be doing that will help people with a long-term illness?
I can jump in because I like to talk. So what's interesting is if you look at the best practice, what's really considered the gold standard when it comes to integrating behavioral health into primary care, it's called the collaborative care model, which is based out of the University of Washington. There's some 60 some odd randomized controlled trials that show, and again, making the business case, that show that if you integrate in this way and using this best practice, the return on investment is $6 over 4 years for every dollar invested in this model. So that is, and I won't go into detail about the model, but that model was developed using a chronic care model approach. And okay, maybe I will talk about the model briefly. Basically what it is you have the primary care doctor as the lead clinician. In the primary care office, you have a behavioral health specialist that does care coordination and does therapy. Okay, and then that behavioral health specialist every week touches base with a psychiatrist who provides consultation around treatment plans and medication management. So the primary care doc can do their thing, but they have the support of a team behind them, and this person maintains a relationship, hopefully a lifelong relationship with that primary care doctor, and so mental illness and using this collaborative care model is taking the chronic care approach. So it's already happening, and when implemented properly, has wonderful outcomes. But that's one of the things we're trying to get done.
And I think, thank you for the question. One of the things I think is important to point out, which I did mention earlier, is when you look at mental health and mental illness, about 1 in 4 Montanans or Americans lives with some kind of a mental health condition, but about 1 in 17 lives with a serious mental illness. So there's just like any other part of the brain or any other healthcare thing, there is a varying continuum of what does that care look like. Like somebody might be seen at their FQHC for 20 years, by their psychiatrist and a counselor there, but there may, for someone who has treatment-resistant schizophrenia, what that long-term trajectory probably, it might include some housing, and the goal may be giving them as good of a life in their community as possible with as few time spent in institutionalization or, God bless, incarceration. And I think that's it is like any other conditions, there are different variation, and I think for long-term wise, I think our state has lost some group home capacity over the years, and especially for our most difficult to care for folks. If you run a mental health center group home, every bed you have is full, and then to be asked to take the most difficult clientele for exactly the same rate when you're basically going to need to double staff that creates a lot of difficulty, and it creates a lot of backup at Montana State Hospital. And I'll be very honest that I worked really hard for 2 years to figure out how to fix that, and I don't know if I could have had a more abject failure in that. So, but we are going to have to figure out that interface between the mental health centers and the hospital and the legislature, and how do we figure out housing for our most difficult to care for clientele.
There's a model. There's a model actually in talking about sort of the severely mentally ill, assertive community treatment programs, which they call them ACT teams, and this is almost like a mobile hospital that goes actually to the home. So, for example, the most severely mentally ill, and there's plenty of research to show that this can be very effective, is instead of trying to prevent further hospitalizations and rehospitalizations, this team sort of wraps around and goes into the home. So that'll include the prescriber, the nurse, social worker, and so they really try to provide for all psychosocial needs, including the medical needs. And it's been great. The mental health center here in Billings actually, I think, just expanded their capacity because also these same people are often the ones who are the high medical utilizers. right? So another reason to kind of think about this. But there are models. It's just how do we get the right funding to keep these models sustainable?
So I just have to touch on that just a little bit because we're talking about funding, and that was the gist behind all of the bills in the last session. On a positive note, you got to understand over the years, long before my time, that all of these chronically ill mental health patients were institutionalized. And if you want to go back 30 years and go and take a look at where we've come to today. And even after 30 years, 40 years, however long it's been, where we've moved away from just institutionalizing those with mental illness to where we are today. And this discussion continues. How do we pay for it? What's the right way to do it? But it's the discussion that's happening, and it's happening at the right levels at the right time. We're going to continue to push because, as Dr. Arzubi talks about, all of the collaborative care models that are out there, they're going to come into effect. Now we got to figure out, and we have to understand, and we have to convince the people in the state of Montana that this is the best way to care for those people. And we talked about it yesterday, the most effective and efficient way to take care of those that have the vulnerable populations in the state of Montana. And the more that we take care of the efficiency and the effective care, the more dollars that are going to be available for all those populations. I just had to put that in there.
So lunch is on its way, so I'm going to pull the plug on this. But as Representative Ehli had mentioned in his comments, you are the folks and your neighbors that can make a lot of difference on this whole mental health subject as we go forward with the legislature in your communities and beyond those type things. So thanks to the panel again. I appreciate your input on this tough topic. Thank you.